Yeah, good afternoon, respected seniors and dear colleagues and students. Okay, so we'll be presenting our CGR on changing trends in diagnosis and management of female genital tuberculosis in infertility. Our experience of last decade, rather almost 12 years. And this I want to acknowledge the help of Central TB Division, Government of India, Ministry of Health. We had 3 projects from them, so on that we did work for last 12 years. And so in this basically, okay, okay, sorry, yeah. So basically, a little bit about and my I'll be helped by Dr. Urusi Singh, who will be presenting about yeah, microbiological aspects, and Dr. Venkat will give some comments about I mean pathology part. Dr. Rakesh Kumar about PET CT, and Dr. Smita Manchanda about radiological investigations. So just a little bit about that. We know that almost 10.6 million people have tuberculosis, out of which 1.6 million die, and 6 million are men and 3.4 million are women. And in India, the trend is no less. We say almost like nearly 1.9 lakhs people are there deaths and mortality. Sorry, nearly 19 lakhs people and 4.93 lakh deaths in India because of tuberculosis grossly. So female genital tuberculosis we know constitutes almost 9% of extrapulmonary TB. So most important is pulmonary TB. In extrapulmonary genital TB is one of the important causes of that. And this causes a lot of morbidity, not mortality usually, but infertility is most common. Others are dyspareunia, oligomenorrhea, or menstrual dysfunction, chronic pelvic pain, chronic pelvic inflammatory disease, and then easily overlooked because of non-specific symptoms and chronic and cryptic clinical manifest. So this is important because normally a patient of pulmonary TB or meningeal TB, they have symptoms, but genital TB patient may be normal looking actually. They are in your clinic and they look like normal. In like Nina and Neeta will agree with me, in their clinic, most of our patients coming for infertility have got this thing. So first I want to present this study of 374 consecutive cases of FGTB diagnosed by composite reference standard, which we'll be discussing, in which diagnostic laparoscopy was performed over 12 years period as part of the 3 projects sanctioned by Central TB Division, Ministry of Health, Government of India. So this was a prospective cross-section study. These are the numbers and etc. And so we grossly we took after taking history, taking examination, and also we suspected them to have genital tuberculosis, and then we did endometrial sampling on them between 21 to 24 day of the cycle with number 4 Kalman cannula, and then we sent this specimen for various investigation, ARB microscopy, culture, gene expert, LAMP, as well as LAMP, various tests we are doing in that project, plus histopath for epithelioid granuloma, and of course for PCR to Dr. Urusi lab and Dr. Manish Suneja and Dr. Sinha's lab, we did some tests there. And these other tests were routinely done on then hemogram, Mentox, blood sugar, X-ray chest, ultrasound, CT, depending upon the patient. X-ray chest was done in all the cases, ultrasound was also done in most of the cases. CT scan, MRI, PET, in depending upon patients with tubo-ovarian mass, selected patients only, because of the logistic problem and financial issues. Culture, PCR, gene expert in all the patients, and third granuloma was looked for that. So this was the flow chart design which we used. So out of almost 2,587 patients, 398 were eligible. 34 were excluded because they were not either meeting the inclusion criteria or declined to participate. So 374 were taken to the study. History taking, general physical examination, gynecological examination, and baseline investigations were done. Then endometrial sampling was done in all of them for AFB microscopy, culture, gene expert, PCR, and histopath evidence of any epithelioid granuloma. And then diagnostic laparoscopy was performed in most of them, excepting where it was obvious AFB or culture positive, then we didn't do. So diagnostic laparoscopy was done for any definite finding of FGTB or possible finding of which we'll be discussing. I mean, Vidushi Kulsrestha has done good work on that aspect, so I think she can give her comments about definite finding and possible and probable finding. And then all patients were given antituberculosis therapy for 6 months as per DOTS principle and under free of cost through government, DOTS strategy. Follow-up for compliance and adverse effect was done. So these were the total patients and the cases not suspicious of FGTB. So laparoscopy was planned in 404 patients, and FGTB prevalence in our study was 17.89%. So traditionally in India, the incidence is supposed to be 10%, but it is higher in AIIMS. It was, I mean, in MEMC also we did study, but it was 9 to 10%, but in AIIMS it's higher because we get referral from Bihar, Jharkhand, the high risk area. So that's why they get concentrated. So this is actually false high prevalence there. And in fact, in patients of patients seeking assisted reproduction, the incidence is as high as 40 to 45%, I think, in Neeta Singh and Nina's studies, basically. So 374 laparoscopies were performed, but Not done in suspected cases were 30. So failed or abandoned laparoscopy in 5 cases, and 9 patients were lost to follow-up. Then inability to see pelvis due to adhesion in 6 cases, and pregnancy happened in 11 women. Cases analyzed for laparoscopy finding were 363, refusal 10 women basically. So these are the grossly were just, I mean, I want to see when they have to see. So this was the just characteristic of these 374 patients. Basically, like in Scandinavian country or European country, the age of tuberculosis is usually 40 years median, but in our country it was 27.5 years. So they are reported age group patients, and parity was of course just 0.29 mean. Until most of them are infertile only, and the body mass index was on the lower side. You can say past history of tuberculosis was seen in 38%, pulmonary 24%, extra pulmonary 14%. This history is very important, and sometimes patient may not give history because this happened in unmarried state. So you have to take history in confidence without disclosing to the husband or sister-in-law, otherwise they may ditch the woman, no, because she had to hide it from the would-be in-laws, no. Then infertility was seen in all of them. So 306 had primary infertility, most of them were primary, 81%. Secondary was seen in 18% cases. Socioeconomic status was lower in 65% and middle in 31%, but it can happen even in upper socioeconomic status. So these were the symptoms. So normally you didn't have, most of the patients did not have obvious fever. It was just mild, more 99 to 100 fever. Then some had anorexia, weight loss, malaise, night sweats, menstruation. But I want to say that many patients, some of them can be have totally asymptomatic patient. Normal menstrual cycle was seen in 51% patient, abnormal bleeding in only 2%. But later on, most patients had either hypomenorrhea, oligomenorrhea, secondary amenorrhea was also there, and some had dysmenorrhea, abdominal pain, chronic pelvic pain, vaginal discharge was also seen in some patients. And on examination, actually, vaginal discharge was seen in more number of patients, 37%. So this abnormal vaginal discharge, in spite of giving them treatment, may also be one of the important signs of tuberculosis, I want to say. And cervical growth later confirmed to be cervical tuberculosis. In fact, it masqueraded as cervical carcinoma was seen in four cases. And this was the adnexal mass. Unilateral was seen in 12% cases, bilateral in 5.8%. Hemoglobin was 11.8 was mean, so they were not actually anemic, but 67% had 17% had anemia. TLC was mean stand was 5585. And similarly, blood sugar was, most patients were normal, and abnormal infectious Mantox test was seen in 142 patients, 37.96%. And then erythrocyte ESR was also slightly on the higher side, 32.74. And X-ray was normal in 88%. Old heat lesions were seen in 6.9%. Mediastinal lymphadenopathy in 4.81%. In that case. So this is the method of diagnosis of male genital tuberculosis in our study. So positive AFB on microscopy or culture 18 and 24, that means 4.8, 6.4% only, and on peritoneal biopsy 3.9%. Epithelial granuloma or chronic granulomatosis endometrium on histopath or endometrial biopsy in 15.5%, epithelial granuloma on 5.88. So Dr. Venkat is there. I think I'll take his comment there. And positive CBNAT. It was done only in 167 cases because it, in the first half of our study, it was not available. So later on, so we could do it in only half number of cases. So 18.56 in them, 31 out of, and then positive on endometrial PCR was positive in most of the patient, and definite finding of TB in 43.85%, probable finding in 55% patient. Some patient had more than one finding. Okay, so these were the findings, and then we divided into time zones. So 10 to 249. I mean, first 5 years, 5 or 6 years, and second 5 to 6 years like that. So, but we could see that though we see BD tubes, bilateral, unilateral, tubercles on uterus, fallopian tube, ovaries, pouch of Douglas, pelvic peritoneum, general peritoneal cavity, cages, nodules overall, pelvic region, general peritoneum, and then probable finding of TB like adhesions, pelvic adhesion, perihepatic adhesion. So they were seen in almost like, say, you can say the percentage by 11 to 12% there, and perihepatic adhesions were very common. Only thing, when you are putting a laparoscope, please do look all around 360 degree. I mean, most of the time we just restrict ourselves to the pelvic area. No, try to look all around. We'll have a lot of finding there. So in my experience, almost 45 to 50% patient had perihepatic or Fitch-Hugh-Carter syndrome. Abdominal adhesions are also there. So this thing, and there was no difference in overall. I thought that like with all evolution of the time, the prevalence may change, but it was almost same, right? Non-significant, and most of the findings were still there. These are the like saggy areas on uterus, fallopian tube. Saggy areas are just whitish areas. You can say then extension of tubercles only, basically on fallopian tube, just like a white carpet has been laid on them. Pouch of Douglas, upper abdomen and liver, fallopian tube findings were unilateral hydrosalpinx, bilateral hydrosalpinx, unilateral pyosalpinx. Pyosalpinx was rare in just 2 to 3 cases only, and unilateral tuborian mass was seen in almost 14%. Bilateral in about 7%, unilateral tubal block in 16%, bilateral block in 9%. So tubal blockage was very commonly seen. Congested hyperemic tube again 24%, right rigid tube again 4%, encysted ascites, fluid filled pockets in pelvis, frozen pelvis. We found that tuberculosis is one of the important, one third of the, I mean, like out of 100 frozen pelvis patient in our experience, almost one third were because of tuberculosis, one third because of endometriosis, one third were because of malignancy. So it's one of the three most common causes of this thing. Inability to see pelvis due to adhesion was seen in about 4% cases. So these are the some figures I want to just show, showing tubercle on uterus, peritubular adhesion, and diagnostic laparoscopy showing cages nodules. I'll be sharing more figures also. Then perihepatic adhesion you can say in this area. I mean perihepatic adhesion for the postgraduates. So like okay, and these were other findings like shaggy region on uterus, left-sided hydrosalpinx, and in this case you can say hyperemia hydrosalpinx or left fallopian tube in the case of FGTB, and diagnostic showing large right-sided tubular mass with cages material coming out in the case of FGTB. I will be showing some more figures later. Another thing I want to highlight was the difficulties and complications encountered during laparoscopy in FGT patients. So I want to highlight it that laparoscopy done for tuberculosis is a high-risk laparoscopy, should be done always by a consultant, or at least supervised by a consultant and not by junior resident and all, because there are many times we found difficulty in creation of pneumoperitoneum in almost 17% cases, insertion of trocar cannula 14%, excessive bleeding could be controlled by cautery in about 5%. Vascular injury, right uterine artery was torn. I was doing laparoscopy myself. Immediately I called Dr. Sunesh was there. We did vertical incision and we just pressed it. In 5 minutes we could control luckily, and it was close to ureter. So that's just have to be very careful about that. Then bowel damage. I have requested Dr. Dash to come because we called him. So small bowel was injured in 3 cases. And then ileal injury in with resection and anastomosis by surgeon in 2 cases, jejunal resection and anastomosis in 1 case. Large bowel injury, laparotomy and colostomy was done later in 1 case. Then we had 2 cases of bladder injury also, and in this case, Rishi came for that case, and it could be sutured by laparoscopy. In 1 case, laparotomy had to be done and repair about this. And then it was actually trocar injury. So when one has to be very careful because of adhesion, sometimes the position of or anatomy changes. The subacute incision obstruction is fairly common in them, almost like 4% patient had postoperatively. Flare of tuberculosis. I mean, Vatsala has also reported this in International Journal TB and I think Neeta Singh also has reported flare of tuberculosis. So it happened in about 4% cases. The increased hospital stay was seen in about 5% patient. Readmission in 2 of these patients were those, like one injury we missed, the ileal injury, we missed it and later on patient came. And wound infection healed with local antiseptic antibiotics in about 5% cases. So you can see the complications are much higher in these patients as compared to non-tuberculosis patients. So basically, this is just a little bit about discussion. I will be calling, of course, Dr. Rusi Singh also soon. So reported incidence of tuberculosis in infertility is about 1% in USA and Scandinavian country or Europe. In South Africa, 4 to 8%. In India, it varies from 1 to 19%. I was talking to like South Indian people in Kerala and all, they have very less incidence. So I in fact offered them to deliver a talk on genital TB. They refused that talk on SUI. We don't have a TB that much. So it's less common there. But in North India, it's fairly common. And higher incidence of 26% tertiary care center due to referred cases to us. And incidence of 48% registered acid reproduction in Dr. Neeta Singh's study. It had been reported that. Okay. But it's not going. Sorry, next. Okay. Okay, so FGTB is seen in case of almost 30% of sputum positive pulmonary TB cases, 10% extrapulmonary TB cases. And typically young disease, say 20 to 40-year-old, but in developed countries 40 years. And at AIIMS we already said 16% and 42%, and 8% of EUB cases are also due to TB. Now, okay, so this is just a little bit about prevalence of genital TB in fertile patients in different countries and different centers in India, almost same thing. So this is, I think, Neeta Singh's study basically 48% and Gupta et al 26% and all, and Tripathi et al 41% like this. Okay. In Pakistan also the study are here, and in South Africa, this is other way around. Patients of tuberculosis with infertility is very, very high, like almost 73% in South African study, and this Bhanutu et al from Hyderabad, our one of our postgraduates, her name, she's working there, na? So 77%. So that most patients will have it. So symptoms are usually, what I want to highlight, that a patient of pulmonary TB will always have symptoms. Other TB always have symptoms, but up to 12% patient may be asymptomatic, but mild fever. It's not high grade fever with and loss of appetite, weight loss, poor general condition, menstrual dysfunction. Initially there will be menorrhea, and post the postgraduate, what happens initially, the tuberculosis will irritate the endometrium, so there will be ulcerative lesion, so that will cause menorrhagia. But later on, tuberculosis will eat away the endometrium, so there will be patient will have hypomenorrhea, oligomenorrhea, and even amenorrhea. And amenorrhea is important. My wife has done studies in adolescent girls. So even in without involvement of genital tract, also sometimes there can be amenorrhea or oligomenorrhea. That is because of antigonadotropic effect of tuberculosis. So even pulmonary tuberculosis patient without involvement of genital TB can have oligomenorrhea and amenorrhea because of antigonadotropic effect of the toxins of tuberculosis. So that's why primary and secondary amenorrhea can also happen in them. And infertility, the most common presentation, primary and secondary, little bit in our study, because we took only infertile patients, these are the one coming to us in OPD. So that's why little bit concentration of infertility patient. But some patient can have mass abdominal pain. This mass is unique actually in compared to ovarian cyst. Ovarian cyst is a well-defined mass. But tuberculosis mass is not a well-defined, it's just more like vague mass. And similarly, abdominal pain, chronic pelvic pain, acute abdominal vaginal discharge. So 38% patient had vaginal discharge. So if the patient is having coming from Jharkhand or Bihar with such big bundle of papers, no, given antibiotic, 20 course of antibiotic last 3 years, so it's invariably tuberculosis. So this is important. And then same way signs. There may be no physical sign in 10 to 12% cases. Then again, fever, lymphadenopathy, TB lymph node, crepitation on chest examination in pulmonary TB patient, mass abdomen, vago definite, ascites, doughy feel of abdomen for the postgraduate is very specific of it, and uterine enlargement because of pyometra, adnexal masses, induration, vague masses actually. Tubovarian mass, fullness and tenderness in pouch of Douglas. In comparison to like endometriosis, the uterosacral ligament will be tender nodular in endometriosis, but in this case, uterosacral are not abnormal, but it's the lateral fornices which are tender and all. And the rare signs are hypertrophic or ulcerative lesion in cervix, vagina, or vulva. And it may masquerade like cervical carcinoma, vaginal carcinoma, vulval carcinoma. Many times we have taken biopsies, it ultimately turned out to be. Then Bartholin swelling, vesicovaginal or rectovaginal fistula. I have seen at least 2 girls, unmarried girls, with one rectovaginal fistula, one vesicovaginal fistula. It was I thought it was some sexual trauma, but there was no such history. So when I took a biopsy from there, it turned out to be tuberculosis. So I gave her ATT and said I will operate, close the fistula later. But have a guess, after 6 months, there was no fistula left. So it can heal of its own by ATT. So never be in a hurry to operate on them. So the causes of infertility in FGTP we know are the tubal factors most commonly, because almost 90% are tubal, ovarian causes, and uterine, cervix, and vulva and vagina. Okay, so this is Nina's article, effect of tuberculosis on ovarian reserve among women undergoing IVF in India. So ovarian reserve, even if ovaries are not obviously involved, but ovarian reserve significantly is lower in these patients, and they require higher amount of FSHL injections also for gonadotropin levels for ovulation induction for these patients. I mean, I'm not expert in that. And similarly, that it is an important cause of IVF failure and latent genital tuberculosis in the clinical setting. So this is the DAM et al. Professor B.N. Chakravarti study from Kolkata, very popularly quoted study. And it's also important cause of Asherman syndrome in India. That means it eats away the endometrium, so it causes endometrial adhesions because of that. And that's naturally these patients will have difficulty in conception. And even if you cut these adhesions, these patients will have difficulty in conception. Now, what is the diagnosis? Basically, family history of tuberculosis is very, very crucial. History of antituberculosis therapy in the past in a close family member, or past history of TB or ATT. So this you have to take in confidence, because this is now a wife of someone. So she had disclosed it from her husband. She had not disclosed to her husband. She had it in and quite often in India, what happened, when the grandfather or father is dying of tuberculosis, the granddaughter is looking after him, and she gets the disease from him. So this is, I have seen many girls like that. So it's a very bad thing. So I wish the boys should look after the grandparents and all, no, because if the boys have TB, it's less serious, no. So yeah, so this history is important. And then general physical examination for any lymphadenopathy, any evidence of TB at any other site in the body. This is very important. I had 2 girls. One, this is the niece of my class fellow. I admitted her. She had tubovarian mass. Any tubovarian mass in unmarried girls, in absence of malignancy or genital, gonadal masses, is tuberculosis if she is non-sexually active. So I didn't know how to do. I thought we'll take FNAC from that. I admitted the patient, and in AB3 ward, next day when I examined her, she had a discharging sinus from her knee. Okay, so I sent call to Ravi Mittal, and then we took sample from there. It grew AFB. Another girl, we admitted her again, TOMAS, and then I saw she had a large lymph node in the neck. We took FNAC from there. I mean, not myself, but those people, and it grew to be TB. So please have a good look at them all around. They may have skin tuberculosis in the skin. They may have in the skeletal system. They may have it in the lymph node. From where it's easier to take sampling, because unmarried girl we can't do endometrial biopsy, and taking FNAC from TOMAS is not very successful. In fact, Urusi wanted us to do it, but we did in 1 or 2 patients, but it was not very successful. Sample was so small, we didn't grow much actually. So you have to examine them carefully. Then chest examination for pulmonary TB, abdominal examination, external genitalia, specular examination, bimanual examination, aids in diagnosis of genital. Test will depend on the site of TB and its clinical presentation. For us, it is endometrial sampling. Has to be done endometrial biopsy unless she is unmarried, non-sexually active. When menstrual blood as a whole has poor I will not recommend it. But in unmarried girls, I mean, you can do it for PCR and AFB microscopy, but pickup rate is very, very low. And then basically, yeah. So okay, so these are the these are index TB guidelines. Dr. Sinha is sitting here, and Vidushi Kulsrestha, we were part of it. Dr. S.K. Sharma was at that time, so we were part of that. And in this, this was published in IJMR also. So these are the patients who were pre-menstrual women presenting with infertility or menstrual dysfunction should be investigated basically, and even ectopic pregnancy patient, post-menopausal patient presenting vaginal bleeding. So this, and we do endometrial sampling is the single most important investigation sexually active woman. Should be, I have already sent 21 to 24 days saline sample, send one in AFB microscope for ZN stain, AFB culture, gene expert, PCR, LAMP and LAMP. And now I'll invite Dr. Urusi Singh, madam, if you can, in 7-8 minutes, you can present your data of ways. So microbiology is the most important investigation to be done. So madam, so we just send sample to Urusi and he does the magic.
Good afternoon all, and I must thank Dr. J.B. Sharma and the Department of Gynaecology to invite me here. I'm not going to deal with a lot of data, but I want to bring in a few areas which are not very well, covered, and less importance is given to them. Next slide. Right, so all this has been covered by Dr. Sharma, and this doesn't really need, the audience doesn't need those details. Now, what I want you to look at is this data. This was from Spain. The moment they were able to have a drop in their pulmonary TB cases, within 10 years, there was a clear drop notice in the FGTB. So this is reiterating what Dr. Sharma earlier said, that it is obviously the source is pulmonary TB, and the spread could be hematogenous or from the tissues surrounding. Most patients have had subclinical FGTB in those with pulmonary TB. So this is what he also said. So again, I'm moving on. I want to actually, I was assigned 8 to 10 minutes. I would like to complete what I want to say in that time. So all this again to the people who are actually dealing with the genital TB is not new. Just a Venn diagram to share with you the number of patients exposed, the subset which is infected, the true active TB, of which a small percentage can be microbiologically confirmed for reasons that I'm coming to later, and another subset who would actually have clinical symptoms consistent with TB. Right. So this is where I would like to spend more time. Now, this is something. Pointer? So if you may please have, if I may have your attention here, what we have to the left of the graph is TB which may happen and may get healed, followed by, we moving from, so we have infection eliminated in those who have a good immune response, followed by those who have latent TB. So we generally talk of just two extremes, latent and active TB. But please notice what we have in between. So there is a zone where we call it as cyclic disease, which could vary. So TB eliminated, followed by latent TB, or incipient and subclinical TB before it is actually active florid TB. And this is the area where the TB bacteria may be actually seen, or they may not be seen by whatever test we may use. So if we compare what can be appreciated in these different stages, during latent TB, of course, there's MTB exposure and person has viable MTB pathogen. Yeah, but then you're not able to, actually look for any metabolic activity or radiographic abnormalities, or person has symptoms, obviously he doesn't have symptoms, and this changes with time. So when we are looking at incipient disease or subclinical TB disease, we may not actually detect all the microbiological signs, or we may not be able to demonstrate the so clinical TB is actually the tip of the iceberg, and we must look at the whole iceberg, and this is the stage which is a subclinical active phase, which may be missed by the gynecologist, though the patient is actually presenting with symptoms of infertility. And as a secondary involvement in tuberculosis elsewhere, again there will be a subclinical active phase, like Dr. Sharma mentioned, the other things like, there can be amenorrhea secondary to a disease elsewhere, secondary to the effect of TB on other organs. Now, coming to the granuloma formation, when we talk of sample collection, this is something which everybody knows, and so when we are comparing a test, if we are comparing whether it's a PCR or it's a gene expert, we're comparing it to the traditional combination of bacteriology, histopathology, and hysteroscopy or laparoscopy. What if those tests have lesser sensitivity than the test in question? For example, PCR and gene expert have a better sensitivity. This is smear microscopy, needs 10 to the power 3 to 10 to the power 4 organisms. But the LJ or the midget, that's the current medium, is highly specific but needs 10 to the power 2 organisms. The other methods that we're talking of need lesser organisms. Now, these are granulomas. A and B show nascent granulomas. Then we have the classical caseous granuloma, and then we may have a fibrocaseous granuloma, and then we have the resolved granulomas. This is Dr. Venkat's field. I wanted to bring this picture in here. When we are sampling, we can only penetrate granulomas which are actually penetrable. So you need the right sample to be able to demonstrate the organism, which may be possible in the top view and may not be possible in the bottom view. And again, this picture I always like to bring in. This is from Robbins, which is the Bible of pathology. At least in our days it was. So the other infectious diseases which could actually lead to granulomas. All right, so specimen collection is the crux. It's easier said that false positive, false negatives, but kindly see that the collection and the viability of the organism will be affected by the methods of collection. Also, if we can actually try and sample the sites of disease activity, the fallopian tubes, cornea, endometrium, rule out pulmonary involvement, which is actually active in 50% of cases, that's what's reported, and good quality samples would improve the output. TST, no role, IGRA, no role. The idea of bringing in these slides was that these have no role. Please do not treat your patients based on IGRA results, which in the private sector a lot of people are doing. It will only detect a CMI, cell-mediated immune response, which may even miss the infection. So it would definitely miss the disease. And also during active disease, the IGRA gives, this is a comparison between so basically I wanted to bring in was the non-sensitivity or the poor sensitivity and poor specificity of IGRAs. When you even follow up patients, there can be variation. We call it conversions or reversions. Monto has no role. CTB skin test has been published recently, but again, no role in diagnosis of disease. Urine liporabinomannan is a test which was initially designed or recommended by WHO for PL-HIV. In the year 2012, we went on to study it in children. We found it highly sensitive in the range of 73 to 76%. There are publications which show it as higher, and in the current study with Dr. Sharma, we are also evaluating the LAM. This is just one of the tests looking at the antigen. Now coming to the nucleic acid amplification test, the gene expert has been, is being projected as the gold standard of diagnosis. But please do remember, one, if the sample is representative of the activity of disease. Two, the sample has to be devoid of all inhibitors. So all extrapulmonary TB samples have actually got to be treated before they're put into gene expert, which not all labs do. Hence, the output or the results would vary from lab to lab. Now, this is 2013 WHO recommendation, and the blackened portion here is our study here, and we've done it in extrapulmonary samples. This is Dr. J.B. Sharma's paper published with Dr. S.K. Sharma. And this is our paper in extrapulmonary TB. Now, briefly upon PCR. Now, PCR in our lab has been there for about 30 odd years, 30 years plus, and the limit of detection is very good. So, we pick up 3 to 5 bacilli per ml. And why I bring this in here is, so possibly we are also picking subclinical TB. Now, false negatives, like I said, the sample needs to be treated properly in the lab. Presence of inhibitors such as host proteins, blood, tissue lysis products, cytokines, etc., released in granulomas. Enzymes that could be released by bacteria could cause inhibition of PCR. Hence, we get false negatives where the suspicion is high. In fact, there are cases where there is frank caseous material and there is inhibition. So, this is the reason for the inhibition. Despite best of techniques for DNA extraction, inhibitors could lead to false negatives. False positives, DNA PCR is highly sensitive. So, when we are collecting many samples in the opening and we are not careful about how we are collecting it, there could be carryover contamination. And the collection point, or in fact the reporting, even in the lab, the carry-on contamination could be picked up. I'm sorry, I'm trying to rush because I don't want to eat into others' time. Now, this is something which is very interesting. As is known in cancers that the DNA may be circulating, transrenal DNA picked up using the best methods could actually help us, and we're doing some work on this. So, to summarize, LOD of PCR is about 3 to 5 bacilli. Smear, of course, needs 10 to the power 4 bacilli. Culture, 10 to the power 2. Granulomas also 10 to the power 2 bacilli per mil. All right, so this is our work with Dr. Tucker's group. Way back, that's when we started. Then the inference of this work was high specificity, high sensitivity. This is other groups that have published. This is our work with Dr. Vidushi and Madam Kriplani. And the inference was similar. We were the first and the only group who actually used messenger RNA to study viability of Mycobacterium tuberculosis. And what we found was the limit of detection of the technique we were using at the time was equivalent to the culture. So we dropped it, did not continue it. Further work where it actually showed that PCR helped deciding treatment regimen, and a good number of patients, I think more than 31%, in patients who were started on ATT based only on PCR, conceived post-treatment. This is the group by Dr. Jindal's group who also found similar findings. Now, this is where I bring in the CMI response to TB infection, which could be present elsewhere, could actually cause inhibition of, the pregnancy. This is biomarkers that could actually help us detect the, Th1 type immune. This is an old paper. The idea of bringing this in here is the inhibition which is caused by a remote high Th1 type immune response, which is trying to fight the Mycobacterium tuberculosis infection. So the take-home messages are like this. Always look for pulmonary TB in patients with EPTB. This has implications for infectivity, isolation, as well as contact tracing. And like I said, in 50% of extrapulmonary, the pulmonary TB is always, one is successful in demonstrating. None of the molecular methods replace culture. So like I said, there'll be false positives, false negatives, which will not be there in culture. Of course, it has the limit of detection is not as great, but it's a good test. It's an excellent test. In fact, in the latest series we're working with Dr. Sharma, we have grown about 45 cultures out of 200 or 300 samples. So 45 MGIT specific cultures which clearly show us activity of disease. DNA PCR can be a signature of TB in the genital tract or elsewhere in the body, meaning thereby when you think it's false positive, it's coming from somewhere, it's not coming de novo. It is highly specific, so please don't call it false positive. Strong CMI in response to TB anywhere else in the body could actually interfere with the implantation of the fertilized egg. Expert MTB yet to be evaluated would be a signature of active disease. He has published with us and with the Department of Medicine. Now, serological tests and IGRAs are a big no. Each patient should be properly followed up after initiation of treatment, because it's only then that you realize whether your diagnosis was correct or not. And thank you. I hope I completed in the due time. Thank you so much.
Thank you, madam, for that. So we'll just continue. Yeah. Okay. So as Madam Urusi has said, so we take endometrial sample and we do all these tests, and depending upon that, then like if AFB microscopy, culture, gene expert are positive, they are definite TB in themselves. LAMP is also definite, and of course histopathic granuloma, Dr. Venkat will say, is also positive. And then if only like PCR positive, then sometimes we don't start only on that basis, or otherwise, then what is the role of so this we have already done. Yeah. So this is the histopathic granuloma slide I borrowed from Professor Venkat. Yes, sir, you want to say anything about Dr. Venkat? Okay. So typical endometrial granuloma may not be formed in genital TB. You want to say something about that? Uh, oh, yeah, in 1 minute you can just say. Just here. No, sorry.
Granulomas take time to form. The endometrium is shed every month. The disease can damage the tube and go away, and still patient may be infertile. And therefore, granulomas, if present, definitely indicate active disease. I absolutely agree with Dr. Urvashi that the PCR and gene expert are able to detect the bacilli, and it is accurately and sensitively and specifically detecting the bacillus. But the issue is that bacillus latent, or is that bacillus growing in the mind? The second issue is, even if it is latent, it can still cause immunological disturbance, which we have demonstrated also in the endometrium. The immune cells get altered, and they indicate that PCR is actually picking up the bacillus. But these may be very few or latent in number, and therefore, in the absence of active tuberculosis elsewhere, patient will not benefit from ATT because the bacillus is not growing that much now.
Thank you, sir. Thank you.
Granulomas take time to form.
Okay. Local lymphocytosis. I was reading a study. I mean, if any, they like on endometrial biopsy, some lymphocytes are deposited there.
No,
is that?
Lymphocytes are normal part of that.
Okay.
Lymphocytes and neutrophils are normal in an endometrium. Plasma cells, now we realize, are quite normal and are present in nearly 1/3 of all Indian patients have plasma cells. In higher numbers can indicate endometriosis. That's also very common in infertile patients. Granulomas take time and may not come in every cycle, so they are very badly sensitive.
Okay. Thank you very much, sir. And they are usually advanced stages if they from the granuloma. Thank you very much, sir. Okay. So, and then, I want to come back. What is the role of radiological investigation? Fortunately, we have Dr. Smita Manchanda and our group here, and Dr. Smriti Hari has contributed a lot of studies. We did together. So, there is a role of on hysterosalpingography. Normally, in a active TB disease, genital TB, HSG is contraindicated because of the flare of the disease. But many patients have HSG done from outside because the patient was asymptomatic. So without knowing they had tuberculosis, they got like HSG done as a part of protocol of infertility for tubal patency. So we have the findings of them. And then ultrasound, CT, MRI, PET, they are done only for tubo-orient massing. Otherwise, not normally. Ultrasound can be done there. So I will now invite Dr. Smita Manchanda to tell us about the role of like, okay. Yeah, thank you.
So I'll be briefly summarizing the radiological features of female genital tuberculosis. These are the HSG findings which are typically seen in female genital tuberculosis. Yeah, so it can involve the uterine cavity or the fallopian tubes. So they can be the endometrial cavity can be small, they can be a beaded appearance of the tubes, they can be blocks at various levels, whether they can be a mid-tubal block or a proximal tubal block. They can be adhesions which are seen as filling defects within the uterine cavity. And in addition, they can be hydrosalpinx, which is the typical tobacco pouch appearance, which are seen bilaterally in this case. In addition, if there are perifemoral adhesions, we may see loculated spill. Apart from that, the calcified foci or nodes in the adnexa can be seen in the plain radiographs which are taken prior to the HSG. In terms of the ultrasound findings in female genital tuberculosis, the most common findings being the complex tubo-ovarian masses as Sir was describing, or they can be hydrosalpinx or pyosalpinx. So typical appearance of a tubular cystic lesion which has got incomplete septations or the cogwheel sign. And in the terms of the endometrial, they can be a T-shaped endometrial cavity, or they can be fluid within the endometrial cavity with irregularity of the endometrial cavity margins. There can be presence of uterine synechia, which would be picked up by a sonosalpingography, and there can be ascites or mental thickening or necrotic nodes. So as Sir was explaining to you that it's not just about the genital tuberculosis or tubovarian or uterine involvement. In addition, the ultrasound, the CT and the MR would pick up other findings which would include ascites, peritoneal thickening or mental nodularity, or there may be lymph nodes and which can be in the mesentery or the retroperitoneum apart from the bowel involvement in cases of tuberculosis. So then we have the CT findings in female genital tuberculosis. Again, commonly the tubovarian abscesses, which can be seen as multilocular cystic lesions which have got thick enhancing walls and thick septations. There may be associated ileocecal wall thickening, which is seen in coronal sections in this case, or there may be bilateral tubovarian abscesses. Apart from that, the mesenteric nodes as well as ileocecal thickening. These are typical hydrosalpinx, that is unilocular cystic lesions which are tubular in morphology in bilateral adnexa. And apart from that, the calcified or nodes may be seen in the abdomen, in the upper abdomen as well. The MR findings are similar, it's just that the signal intensity varies. So because the lesions have got some proteinaceous content, which is seen as the pyosalpinx or the debris on the ultrasound, they may be seen as T1 intermediate to hyperintense, which are T2 hypointense, bilateral cystic adnexal lesions which have got a complex morphology. When we give the contrast, there's a thick rim enhancement of the lesions as well as of the septations. In addition, we can see the mental thickening, the peritoneal enhancement and nodes and ascites. So this is about the summary of the MR findings. Thank you.
Yeah. Thank you very much, Dr. Smita, for beautifully highlighting the various radiological findings. So if you can see, they are seen more role is there in tubovarian mass. Routine, I mean, at genital TB, they may not be useful. Then the role of PET CT. PET CT is an like an expensive investigation, so should be done judiciously, but it has a wonderful scope. We're lucky to have Professor Rakesh Kumar. He can differentiate between tubovarian mass because of tuberculosis and ovarian cancer, which is very relevant because many times we have done laparotomy on these patients thinking it to be ovarian cancer. It turned out to be tuberculosis. So we can avoid unnecessary laparotomy on these patients. So can we have Sir's slide? So there is a role of a PET CT and how Dr. Rakesh Kumar is there to tell. Sir की slide निकाल दो.
So what are the bases of FDG? Normally FDG PET CT is being used for the malignancies, for the staging, for the response evaluation. But we have seen that there is a upper regulation of GLUT receptors by variety of stimuli as a result of infectious processes. And there are variety of cytokinins and growth factors which are responsible for the increased FDG uptake in these patients also. This is one inflammatory cells. There is an increase in GLUT receptor and there is an increase in hexokinase enzyme. So like similar to what we eat glucose, so it is converted into glucose 6-phosphate by hexokinase enzyme and then taken for the glycolysis. Same way FDG is converted into FDG 6-phosphate. And then cell come to know this is not the same substrate for the glycolysis, so it is trapped here. So that make the basis of FDG uptake in these. So this was one a long time back. I was invited to write a reviews. Normally it was invitation by this clinical microbiology review where impact factor is 50 plus. So there we have mentioned that FDG PET can be useful for the site of the biopsy, not for the diagnosis. So we do whole body scan and we see where is a area of increased uptake and then we can say, okay, this is most probable site for the biopsy. We do this in PUO, patient of fever of unknown origin from the medicine department. And then most important role is the extent of the disease. So we tell whether disease is localized or it is extension, multiple organ involvement is there and how much is the disease burden. The most important role is coming is treatment response. Till now, there is a notional that we give 6 months or 9 months or 12 months. So we are not doing this on the basis of some evidence. So now with PET CT, we are treating these patients with definite evidence that when we should stop this treatment. So this is patients with
pelvic tuberculosis, genital tuberculosis. Patient was having a breast mass, presented with breast mass. So we thought it could be, this is a mammography. So we thought it could be a CA breast. That is why patient came to us. But it was a genital tuberculosis. And in addition, there were multiple retroperitoneal and supraclavicular lymph node also. Another patient, you can see multiple bone lesions also. So we need to see extent of the disease in this patient. Since PET scan is a whole body modalities, we can find out where is the best site to take biopsy. This is one of the patient from Dr. JB Sharma group, and you can see this is ascites, this is uterus, this is TO mass, and uptake is seen on the TO mass also only. So you can see this pathology is showing intense uptake, and then patient was received treatment, anti-tubercle treatment, and now ascites is left, but you can see this mass is treated and no more uptake is there. So you can say that patient has been treated. This is patients, you can see known case of genital tuberculosis, big TO mass, treated with ATT, but even after treatment you can see new lesions here. So there is a progression of the disease in spite of the ATT. So maybe having some resistant MDR patient. Okay, this is another patient. This is again post ATT, and you don't see any uptake. This is physiological. You don't see any uptake. So this patient is not having any recurrence of the genital tuberculosis. Continuing this work we have done with Ravi Mittal is here. Some work, and we identify the treatment endpoints in the skeletal TB, and it was published last year, and we demonstrated that PET-CT is an excellent tool in estimating total disease burden and assessing the treatment response, when to stop ATT. This is one example, classical example. This patient is having pulmonary TB as well as bone TB, you can see. So if you see the dates, by the 6th month, there is nothing in the lungs. So pulmonary TB is resolved. However, if you see the bone TB, there is a prevertebral cold abscess. There is an increase initially. So that is a flare phenomena. And later on, even at 6 months, there is a still active disease. So you cannot treat this patient within the 6 months. So you have to treat it differently. Patient was treated up to 18 months. Now there is a no more active disease. Thank you for your kind attention. That's all from my side.
Thank you very much, sir, for beautifully highlighting. So that is the great role of PET-CT, that after, many times like lymph node persists even after ATT. Same way TO mass may persist. So we don't know whether it is active disease or remaining disease or MDR resistant. So for that, PET-CT can really help us. So thank you, Dr. Rakesh Kumar, for guiding us in these patients. And because with just a remaining mass and there is no activity, we don't have to give the drug to the patient. So I'll just take another 5 minutes or so. Yeah, that's already been covered by sir. Yeah. Same thing. Okay. So laparoscopy is the most important reliable tool to diagnose HGTB, and as Nina's study has proven in last year, published in Journal of Gynaecology in USA. So various studies have already done. It can masquerade, tuberculosis has masquerade as abdominopelvic tuberculosis, and we published a study in archives with the help of, we took study from MMC Lady Harding GTB. We combined cases, 26 cases where we had opened those patients for this thing. These are the other laparoscopic findings. I mean, hydrosalpinx and all. These are the just cages, nodules, here. Just want to show, and frozen pelvis. Okay. So various adhesions are very common in these patients. So perihepatic adhesion, Fitch Hugh Curtis known traditionally by Fitch Hugh in 1924, they described it for gonorrhea. Later on, it was described for chlamydia also, and then we found it in case of tuberculosis also. So please do look into that area, and you can see how the tubes are totally calcified and also very unfortunate for the patient. It will be very poor, for infertility. I'm sure the infertility, Nina and Nita will agree with me, but prognosis for fertility is going to be very poor for this patient. These are the various cages nodules on the peritoneum. So please do look all around. You can see various findings. Again, cages nodules. Again, yeah, endometriosis. Normally, if you see endometriosis, TB is ruled out and vice versa. But the two are so common. We have published study in which this patient had endometriosis plus she had tuberculosis also proven. So the two can coexist, and basically. Again, this angry looking uterus, fallopian tubes, this alone is not diagnostic of tuberculosis, but she had positive PCR and infertility and other findings, so probable finding. Again, hydrosalpinx and this thing. These are convoluted tubule, probable finding. And possible finding, again, saggy areas on the tubercles on the uterus and this thing. Again, this is the, yeah, if you see perihepatic adhesion, I was saying, so gallbladder becomes hanging upstage. Can you see in the first stage, little bit, grade 1, grade 2, grade 3. In grade 3, this is vertically hanging and you can see cages nodule there. So that proves that it to be tuberculosis, not otherwise, other way around. Then this was the blue python sign I have described. In this case, when you put dye in these patient, in case of normal tube, it just flows. But in case of tuberculosis, it trickles, slowly it goes. Ultimately, it will, after, if you continue to stay there for with the laparoscope, after 2 minutes, it will go down. So it is delayed spill basically. So it's very peculiar of tuberculosis again. And this is the patient, you can see cages nodule there. Both fallopian tube got fused to each other because the cages material. So too much love is bad. So kissing fallopian tube sign, okay. So this is unfortunate for the patient, for prognosis for fertility is going to be poor. Then this I have seen in ascending colon, lower 2/3, upper 1/3 junction, there is a 5 into 3 centimeter band in almost 38% cases. And I thought about it that the region is probably ileocecal region is the most common region of tuberculosis, ascending colon also. So by the time you go to transverse colon, descending colon, disease becomes less common. So that's why adhesions are more on the right side. And this is the again dry tree branch sign. This picture was told by Dr. Smita also. So can you see the tube look like dry tree? And when I did laparoscopy on the same patient, can you see just tubes are totally dried up like a dry tree? There is a tree near IIT, so it resembles that, you know. So dry tree branch can be unilateral or bilateral. Okay. And then parachute sign, well, you know, same thing I saw. This is the right ascending colon is totally adherent to the anti-abdominal wall. This has great significance for laparoscopy. I mean, people who are doing laparoscopy. If you put the second pot on the right side, you will go through and through the ascending colon, and Dr. Das will not like you. No, it will make a hole. Okay. So this is, and now you say how can I say it is tuberculosis? Next slide. Can you see small cages nodules on this? So it look like I thought should I give it a parachute sign or this our peacock sign, but I ended up in parachute sign. You can see cages nodule there. Okay. So this thing. Then another sigmoid colonic adhesive band also I found. So there is a 5 into 4 into 3 centimeter band. In fact, just last week I was showing to my residents, you know, this sign again. So again, I mean, descending colon and transverse colon disease dies down, but then the again sigmoid again, because it is close to the genital area. So again there is a sign. Again same sigmoid colonic adhesive band is there. Then you can see other adhesions also there. I'm just about to finish all around. Then there is a compartment sign, you know, just like disease try to be settled in one corner of the disease, right lower compartment, right upper, left lower. So that's a compartment sign. And this is the new sign, white cotton ball sign, just accepted and published in Journal Minimally Access Surgery. You can see, can you see this is such a big ball of the cages ball, almost size of the uterus, 5 into 4 centimeter. This is the first time, beautiful ball. So it is a like white cotton ball sign in tuberculosis. And there is a small cages nodule upper part also. So please, I mean, do look into the various signs are there. Then histoscopic observations are there. So where you can say adhesions, tubercles, and you know, pale cavity, like grade 3, 4 adhesions. So these are patients are, even if you do adhesiolysis on these patients, prognosis of fertility is going to be poor. So these are the various, like, you know, and composite reference standard is like you can combine various tests basically, like AFB microscopy, culture, histopath, LEM, like etc. plus laparoscopy, positive finding or probable finding, like that. Then you can pick up more number of cases. And then the treatment now, I mean, initially we used to give 9 months to 12 months, just like Ravi Mittal gives for a skeletal TB, or this meningeal people give for 12 months and all. So, but then this study proved that Dr. Govind Mukharia did in abdominal TB. So both our studies proved that 6 months was as good or as bad as 9 months. No, basically. So this is, and now the treatment I'll just last 2-3 minutes. Okay. So it is important we correctly diagnose the disease. So now you have only 3 categories. I'll skip this slide actually. Okay. So we have, if it is a drug sensitive TB, very simple these days, 2 HRZD for 2 months, 4 HRE for next 4 months, continuous daily dose. And CAT 3 was withdrawn, CAT 2 was withdrawn, and daily was introduced in 2016. So this is what we do for the postgraduates. So for drug sensitive TB, that is true for pulmonary TB and other extrapulmonary also. So 2 months of HRZD daily, then 4 months of HRE. And if the patient has got, I'll just skip this slide. If she has got isoniazid resistance, then you give 6 to 9 months of levofloxacin and REZ. This uniphasic, give it continuously. There is no intensive phase or continuation phase in this case. So maybe Manish or Sanjeev Sinha can tell me better about it. Okay. So just like, so there is a multi-drug resistant can also develop in TB. We presented 6 cases, which 2 were pure primary genital TB. So if you catch the disease in the first place from, you know, it can be MDR. If the source is MDR, then you can catch MDR. But 4 patients were actually concomitant. They were pulmonary MDR TB with the TO mass or lymph node TB with TO mass. Then it's likely that it will be there. So there are 2 regimes for that, shorter drug regime and longer drug regime. That's too beyond the scope of this house. I mean, today we'll refer the patient to Sanjeev Sinha or I mean our TB people. And then this gives, so but non-severe genital TB can also be given this 6 months of bedaquiline, levofloxacin, ethionamide, clofazimine, pyrazinamide, high dose of INH and ethambutol, followed by 5 months of levofloxacin, clofazimine, Z and E means pyrazinamide and ethambutol. Or if the patient is severe disease or with pulmonary TB or HIV positive, etc., then you have to give full longer regimen, which is 6 months plus 12 months, like that. So that's it. So most patients will tolerate the drug purely. Leave it little. Don't do LFT. Otherwise, little bit derangement is common in these patients. Okay. And same way, avoid surgery because more chance of complication. We have seen increased complication rate in laparoscopic surgery or in laparotomy. This is the patient I opened for malignancy, but there was cages material, so I just came out. Take biopsy. Don't try to remove. I mean, do the surgeries. Okay. Similarly, in laparotomy also, the assisted reproduction is very common. Very important for these patients. So this, this is the various studies that in genital tuberculosis, but sometimes there have been a case report of congenital tuberculosis after IVF or even flare up of the disease. So just last, if we repeat the laparoscopy after 6 months of ATT. Now there are 4 scenarios. Tubes are patent, endometrium is normal, try ovulation induction. Tubes are blocked, endometrium is normal or grade 1 or 2 adhesion which can easily be cut. Refer the patient to Nina or Nita for IVF and embryo transfer. Okay. Tubes are blocked, severe intrauterine adhesion, not amenable to resection. Then surrogacy drugs provided ovaries are normal. Okay. But if even I have seen ovaries also disappearing, TB eats away ovaries also, then this patient goes for adoption. So don't let her sell her house or belongings, and then at least Just recent advanced immune factor nuclear receptors are there. Just some new studies are coming. This Nina's group has done, Dr. Venkat Iyer also, chemical evaluation. So our answer will come from these. if you do in early stages, another study of Nina, that they have perifollicular Doppler blood flow poor in them. After ATT, it becomes better. And similarly, that this THA1 response converts to THA2 by ATT. Immunomodulation also happens. And this is like if you after giving ATT, that things get better with them. So ovarian reserve again, and this study already covered. So the immune factors are poor in these patients. So that's it. Okay, yeah. And this is a study by, so there is some role of, autologous stem cell transplantation. Nita published these, I think, 2 studies of that. And I think Nina has got a good, big project from ICMR on autologous stem cell transplant in these patients. So that's my last slide. Thank you very much. So this is an important cause of infertility in developing countries like India. Diagnosis by history, clinical examination, investigation, laparoscopy, cystoscopy, and DOTS strategy under NTEP. Surgical treatment rarely required, only laparostro and drainage of abscesses. Don't try to do THBSO. You still have to give ATT to them. Prognosis for fertility is poor. IFET is, in absence of endometrial disease, may be tried after ATT. It gives stem cell therapy may have a role in regeneration of endometrium. Thank you very much. Yeah, in that patient, madam, actually this patient had, it was not done in your lab. This patient came from outside. They did culture, and that culture grew actually. Endometrial culture, it was done in, I think, in Gangaram hospital, and then patient came for me for treatment. On ARB microscopy grew culture, it was MDR.
Culture showed the
Yeah.
I wanted to bring in this first. If we are using gene expert to talk about drug resistance, so when the count is very low, there can be a false resistance detected. So
in our study, none of the patients actually did this gene expert. All were rifampicin resistant. But one option is that that rifampicin resistance can come on gene expert. This patient had culture.
So the science behind it is, if the number of bacteria is less, the probes will not have enough binding, bacterial DNA to bind. It can be false resistance. So especially in very low, one should always repeat or rely on phenotypic DSC rather than use the single report of gene expert reporting the rifampicin resistance. This is true for all extrapulmonary or pulmonary with very low, especially ultra, very low can be, misleading.
So as Madam said, it has to be by the culture DSC. Thank you very much. So now I request Dr. Manish Suneja, Dr. Sanjeev Sinha, you want to just your comments please, and thank you. Tarpur.
of all, I would like to congratulate Sharma for excellent presentation. Very nice publication. I would like to congratulate everyone. And I just would like to tell, I've done few studies with Professor Sharma, and we have facility of IRL that is funded by CTD under National Tuberculosis Elimination Program. And we have facility of gene expert, we have midget, we have line probe assay, we have other tests, gene expert, ultra also recently we have taught. So I think very nice presentation. We have docs facility also where we can give the treatment both for sensitive and practice. Thank you.
Thank you, Dr. Manish.
But I would just from the for a message for people who are not from gynae or OCM. Okay, so phenomenal work, sir, with very highly granular data. So what we see in clinic is two group of patients. Basically, one group is patients, obviously infertility patients, who are having symptoms and are having some radiological abnormalities. So that group is quite easy to manage. We have something to diagnose, sample, and follow it up radiologically. The second group, which is more problematic, challenging, is asymptomatic. Asymptomatic means infertility is there, otherwise asymptomatic, and radiology is negative. And we see so many young ladies coming to us with some inflammatory markers positive or a latent TB test positive, and they are put on ATG from outside. So that is a difficult group because we know none of the tests have that good sensitivity or specificity to diagnose active TB, and there is a risk of overuse of ATG. So what is important in such patients is the past history of TB. So you see 20 to 30% of patients of TB in India, of infertility, they have had past history of TB. And as we saw today, 39% of patients in this cohort. So this is very important. So, and when laparoscopy has been done in these patients, they have found that majority of these patients with past history of TB have had tubal abnormalities. That means they had an unidentified genital tract TB in the prior episode of TB. So now coming to the message to all our residents. So whenever we are treating TB in our clinics, whether it be CMS, nodal, pleural, bone, whatever it is, we need to be a little bit more diligent to actively look for any involvement of in young females in the childbearing age group, to look for any active evidence of TB there. So that would help in future management of these patients, will avoid unnecessary ATG in such patients. And regarding treatment outcomes, yes, majority respond to 6 months of treatment, hardly if you require extension of treatment. Thank you, sir.
Thank you, sir. Dr. Das was involved in some of our complications. Thank you for saving us, sir. So I want your opinion.
Thank you, sir. For the last 15 minutes, you have been saying 2 minutes.
Okay, thank you.
It's not finishing. That shows that you are overflowing with knowledge of tuberculosis and genital tract. Commendable job by the gynec department. I just went through internet yesterday and I found tremendous amount of publication. Thank you for calling me at the last of the presentation, and that's exactly what happens in the case of call at the last moment. And that is good for the person. I'll tell you how. Now, I did certain practical things. How do we approach? If you have 100 cases of tuberculosis, then 5 would be abdominal problem. Out of those 5, 1 would be urogenital tuberculosis, maybe a gynecological one. Now, what happens mostly that either it is coming through the intestine or in stricture, perforations like that, or it is coming from the peritoneum. The peritoneum exudates, which is a very sticky one, and then it causes adhesions. And next to the adhesions, what happens? What I call it as 4 steps. First one is just flimsy. You just separate them separate. The second one is fibers. You have to be very careful in doing the dissection, otherwise you injure the bowel. Third one is fibrosis with vascular reaction. This is where the dissection is extremely difficult. And if you are not cautious, you don't use a loop or something, it takes hours to do that, you are certain to injure the bowel. If you injure the bowel in tuberculosis, the patient will have a hell of a time. It will not heal till the tuberculosis treatment is over. Now, the fourth one is the worst form, wherein after the adhesion, bowel to bowel inculcation occurs. I think they get incorporated in one another wall, or they will form a fistulation. So I would put 30% to the second category and third category, which we see in your cases. So these fibrosis ultimately at times can form cocoon-like thing. I can tell you one example of a VVIP patient as operating. He was on liquids for years, and when I opened the abdomen, I didn't find any bowel. I went back to the CT scan. They were visible, and then somebody said that we ultrasound, did ultrasound, could see the peristalsis. They were actually pasted to the posterior parietal wall by cocoon, by a thick tape, and it took 8 hours to us to do adhesion and fully then complete. Is doing well. So when we get such a call or opportunity by your department, there are two ways. Either the bowel came first and part of it is the urogenital, or the urogenital first, then the bowel comes. Mostly we believe the idea that urogenital, the genital part is because of the migration of the bacilli or the inflammatory material through the tubes or the lymph nodes. So the nearest organ first to be involved is the sigmoid colon, the sigmoid dysentery, or a rectum. So earlier on, when we were, and they can form obstruction, or you mostly they find incidentally on the OT table, they are stuck to each other. So that's where we are needed. Earlier on, what we used to do is when we were called, means 10 years back, we would be glove in hand, dressed up, kuch to karke aana hai. So we will go in, resect something, anastomose something, and end up in problem. Now, over the period of time, what we learned is 80 to 85% of these people can really respond well to ATT. So we have become absolutely conservative now. So when you go in now, we go like this. So we have a look, and then we say if it is really required, means ATT failure, complete obstruction, or a blind loop, we resect or do something. Or else we just divert, or do we adhesion, come back and wait what is happening. So that is the change.
Thank you very much, sir, for that. I request Dr. Neena Malhotra, please, just give your comments. Hai na? Yeah.
I think you said so much, there's nothing left.
Give comments.
Just one thing that I've been observing, it may be, as you already pointed, that there is so much immunology. I somewhere see a lot of disseminated tuberculosis coming off late in young reproductive age groups for women post-COVID.
Absolutely.
I just can't answer this, but I think, Rishi, it's time for food for thought. That should be look up, has somewhere the immune markers altered in, 2 a week is the kind of norm I take sometimes.
In fact, this is the observation from most of the pulmonologists in TB hospitals. They say we see florid TB, the whole lung is chewed up. I mean, that's post-COVID, because those patients stayed at home, could not reach the treatment centers, never got the treatment in time. So we are dealing with difficult to treat TB, and as Dr. Neena points out, it will spill over to other organs as well. Just one thing, Doctor, you have published, Dr. S.K. Sharma has published that 6-month treatment. I would say Dr. Rakesh Kumar can actually help us with the endpoint definition which we do not have today. We are just doing, like you said, without any strong evidence, we stopping the treatment at 6 months. I don't know how many relapses your department may be looking at. Once they have the babies, they don't come back to you.
Yeah, that's
So I think the biggest use of this CGR will be we have got everyone together, no? So you can make friends with them and then they can help you. No? And Dr. Neena, please want to, Dr. Neena, yes, sir, please. Sir.
So I'm just answering Dr. Neena's question. Actually, during COVID, we had plenty of patients, but because of lockdown, they are not coming to the hospital. So they were at home, and they developed kind of tuberculosis. And in between, once they are enrolled, in between they did not come for taking the drugs in the clinic.
But these are those which I'm highlighting without a past history or childhood history, no contacts, and educated patients.
Yeah,
Nothing like
definitely
Immune
factors have.
For tuberculosis, they have cough, but for EPTB, they don't.
And this is all EPTB with the
Yeah,
abdominal and
so
genital.
EPTB was more common during COVID
Not
period.
funny.
One is because of lockdown or because of other reasons, they are not coming to the hospital. And second thing, it may because some immunocompromised.
steroids. That people
And
got
steroid
so much
and the,
steroids.
because they have.
Because of TB, this COVID TB has gone back by 10 years. All the gains we had, no, I think it was ignored.
So one question you talk
Yeah, thank you.
how, like PCR, its own PCR sensitivity is very high, 80%. So what,
80% is a misnomer. There is some mix up with the data. It's never
I've seen
80%.
in the-
Several studies we published over several years.
Our data was 43.
43%.
43.
So I've seen in one of the publications, that's why I'm asking.
So it's ranged between 20 to
Like Gynaecology have less sensitivity.
No,
So
no,
in
it's not
your
doing.
cases who have PCR positive, infertility patient, how many after treatment get, pregnant?
Pregnant.
We do not treat patients based on only PCR.
That's what I'm asking.
For patients, we have to look at their clinical signs, symptoms, plus minus some other tests to corroborate that the patient has active disease. Just mere basis of a positive PCR, we are not treating them for tuberculosis. So if we
Okay,
find
please.
some other tests, like if you do a laparoscopy, you find tuberculosis, you find adhesions, you do hysteroscopy, you find adhesions, patient has oligomenorrhea, hypomenorrhea, she has infertility, of course, she is not CDHT fast, we do treat them. And if the tubes are blocked, definitely should not get pregnant of her own, she would be referred for IVF. And as Dr. Meena is also doing some work, and there are recent publications showing that the patients who have tuberculosis or who have been treated with tuberculosis have some kind of immune disturbances in the endometrium. So the implantation rates are of suboptimal range as compared to the patients who do not have tuberculosis.
But roughly sir 20 to 30%. Dr. Ravi Mittal wants to.
Dr. Venkat should have also shown
हाँ,
that.
take sir. Dr. Ravi, हाँ. Dr. Ravi Mittal had done a lot of work on skeletal TB. So yes, sir. Skeletal and genital are they resemble each other, no?
One is regarding the treatment, diagnosis, another is regarding the treatment. Now, most of the recommendations on tuberculosis have been from the chest physicians, and chest TB is a multi-bacillary disease. Whereas bone and joint tuberculosis is a polybacillary disease. Letters of pus would contain only one mycobacteria. So the problem lies in diagnosis. So all the tests that we have, Gynaecology, PCR, most of them are negative when we send the sample. So we are not understanding whether it is a sampling error, a transport problem, or a problem at the lab or whatever it is. So we understood that the number of bacilli determines whether it is going to be positive or negative. So I think some recommendations should come. What should the people like us who are dealing with polycystic disease do? So we end up relying only on histopath, and at times also that shows chronic, non-specific
Clinical.
inflammation. So we are relying on clinical rheological parameters.
Same here, sir.
We are not even doing the endoscopy for that. The other point is the endpoint of treatment. Pulmonary tuberculosis 6 months ATT finished.
No, sir. Relapses do occur, which people don't account for, don't follow patients.
I agree. So the recommendation, the government of India recommendation is 6 months. If you read
WHO.
the recommendation, and there was in 2016 they came out with recommendation for extrapulmonary tuberculosis. They talked about every organ in the body, and for us they said 6 months of tuberculosis may be extended to 12 or 18 months on a case-related basis. Now, how to say that particular case for 12 or 18 or more than 18, it was not defined, and it has not been defined in literature till now.
Yeah, that's
What we have been doing traditionally, without any scientific basis, was 18 months. Now, most of the studies were based on recurrence of the relapse rate of tuberculosis, and they found that if the duration of tuberculosis was increased, the relapse rate was less. And it decreased by 5% for every 6 months of increase in treatment. So, it is 18 months, but if you read the literature, it is very, very variable. So, we conducted a study with Dr. Rakesh Kumar, and we proved that even the soft tissue lesions, because bone and joint tuberculosis is not a primary disease, it is coming hematogenously to bone, so we have lesions in lymph nodes, psoas abscess, gluteal abscess, pulmonary tuberculosis, and even vertebra. So we were looking at both at the soft tissue and the bone, and both the bone and the soft tissue took more than 6 months to heal. Now I think to date,
PET scan is the only objective parameter to document healing of tuberculosis. The rest all is subjective. There's nothing objective about it. I don't know how do permanent people document healing of tuberculosis. I think it's radiological and clinical, and that's what we have been doing traditionally for bone also. But PET scan gave us the opportunity to document it objectively whether the lesion has healed or not. Even MRI cannot tell you whether the lesion has healed or not, because inflammation and fibrosis give some edema in the MRI. So we found in the lymph nodes, which is the supposed to be 6-month treatment only, they healed from, they took more than a year to heal. So I think we should revise our treatment guidelines. I'm not the person to do that, but we have probably the first evidence to say that the treatment of 6 months is not enough. I think it came from WHO. The whites gave us this treatment because they were not.
They didn't have enough
the problem.
enough
And
They didn't have enough
they were saving on their resources. They were saving on. See, DOTS was an utter failure. It came from WHO. Those whites was they used us as guinea pigs. Experimented everything and screwed up our population for so many years, and that is why we have relapses, recurrences, Wilson's.
Thank you, sir. Point well taken. Thank you. Dr. Ashok, you want to say just last? Dr. Ashok Sharma is from Lab Medicine and Biochemistry. We are doing DNA methylation studies in tuberculosis in Sona's thesis for him.
And I am happy methylbacteria agree immune cells play very crucial role in that. And my question that we need to understand the post-pathogenic immune infections, because epidemic method emerges branch of science, biomedical science, which play all the aspects of like stress, economic status, treatment, lifestyle. And I'm happy with Dr. J.T. Sharma and Madam, we are already working to explore the epigenetic mechanism of tuberculosis with one PhD students. And along with the genome, epigenome is very crucial to understand the etiology, prognosis, and diagnosis and treatment of any patients. So that is my list. I want to tell you, we need to understand the molecular biology and into the basic science during the patient treatment to understand all these.
Thank you, sir. Dr. Renu Misra, Dr. Vatsala, you want to say something? We thank everyone. Anyone wants to say, Vidushi, you have done a lot of work on tuberculosis. So thank you very much, everyone. And it's a good area. So please, the tuberculosis, don't think tuberculosis, why should I work on TB names? No, it's a very good area to work on. You get recognition all over the world. I get letters from email from San Diego, USA, from Boston. I have got American doctor asking me, Dr. Sharma, I have got 3 patients, all wives of Indian software engineers. They have genital TB. Please guide me how to treat them. So I sent my publication and he said, thank you very much. I haven't heard after that. So thank you very much. Thank you.